Welcome, medical students, to today's lecture on the pharmacological management of gout. Gout is a complex and chronic disease characterized by hyperuricemia and recurrent inflammatory arthritis. In this lecture, we will explore various pharmacological agents and therapeutic approaches used in the management of gout. We will delve into the effectiveness, mechanisms of action, and potential adverse effects related to each treatment modality. Let's begin our discussion with an overview of the available treatment options and their comparative efficacy. Allopurinol and febuxostat are commonly used drugs for treating gout. They work by inhibiting xanthine oxidase, which is involved in uric acid production. Allopurinol is the preferred first-line option due to its efficacy, affordability, and safety. Febuxostat is an alternative for patients who cannot tolerate or do not respond to allopurinol, but it is more expensive and has limited long-term safety data. Pharmacogenomics is essential for personalized treatment of gout. Genetic variations in enzymes and transporters affect how patients respond to medications. For example, HLA-B 5801 is linked to severe skin reactions caused by allopurinol. Alternative drugs like febuxostat or pegloticase can be used instead. Genetic variations in transporters like URAT1 and OP1A1 affect the response to uricosuric agents. Customizing treatment based on these genetic factors can improve outcomes and minimize side effects. Emerging evidence suggests that SGLT2 inhibitors, primarily used in the management of type 2 diabetes, may have additional benefits in the treatment of hyperuricemia. These agents, including canagliflozin, dapagliflozin, and empagliflozin, lower serum uric acid levels through their glucose-lowering effects and the inhibitory action on renal tubular reabsorption of uric acid. Clinical trials have demonstrated that SGLT2 inhibitors, as adjunctive therapy to ULDs, provide an additional reduction in serum uric acid levels. This dual mechanism of action is particularly relevant in patients with gout and comorbid type 2 diabetes, as it addresses both conditions simultaneously. These findings suggest that SGLT2 inhibitors may have a role in the management of gout in patients with type 2 diabetes and hyperuricemia. Uricosuric agents, such as probenecid and lesinurad, increase the excretion of uric acid by blocking its reabsorption in the kidneys. Probenecid competes with uric acid for a transporter, while lesinurad inhibits another transporter. These agents are particularly useful in gout patients with low uric acid excretion. Probenecid may cause kidney stones, while lesinurad carries increased risks for renal and cardiovascular events and is often used in combination with another drug. In some cases, gout may become refractory to standard therapies or present with severe manifestations that necessitate novel therapeutic approaches. Pegloticase, a recombinant uricase enzyme, offers a unique treatment option for refractory gout. It works by converting uric acid to allantoin, a more soluble and easily excreted compound. Pegloticase is administered intravenously and has been shown to substantially lower serum uric acid levels in refractory gout patients. However, its use is often limited by the development of antidrug antibodies, increasing the risk of infusion reactions. Close monitoring and appropriate management are crucial when considering pegloticase therapy. In summary, gout not only causes inflammation and pain but also has serious implications on bone health and joint function. Targeting bone remodeling pathways and promoting joint health are important strategies in managing gout-related bone erosion and preventing joint damage. Uric acid crystal dissolution agents, such as high-dose oral or intravenous corticosteroids, can provide significant symptomatic relief during acute gout flares. These agents work by suppressing the inflammatory response and reducing the deposition of uric acid crystals in affected joints. During acute flares, oral corticosteroids, such as prednisone or prednisolone, are often initiated at high doses and gradually tapered down over a few weeks. Intravenous corticosteroids, such as methylprednisolone, are reserved for cases where oral administration is not feasible or when prompt relief is required. It is important to note that while corticosteroids can effectively control acute flares, long-term use should be minimized due to their potential adverse effects, such as increased susceptibility to infections, bone loss, and metabolic disturbances. New research shows a strong link between gut bacteria and gout. Gut bacteria affect the way our bodies process and eliminate certain substances, like purines, which are involved in gout. Changing gut bacteria through probiotics or other interventions might help treat gout, but more research is needed. Some patients with gout do not respond well to xanthine oxidase inhibitors like allopurinol and febuxostat. This can be due to genetic factors, drug interactions, or inadequate dosing. Emerging therapies like topiroxostat and arhalofenate target these resistant cases by offering alternative mechanisms of action. These novel therapies aim to provide more treatment options for patients with xanthine oxidase inhibitor-resistant gout. During acute gout flares, it is important to control inflammation for symptom relief and joint protection. Nonsteroidal anti-inflammatory drugs, NSAIDs, like indomethacin and naproxen are commonly used as first-line treatment. They work by reducing inflammatory responses, but caution is necessary in patients with contraindications. Colchicine, an ancient antimitotic agent, is also used to manage gout attacks by inhibiting inflammation through various mechanisms. It is a valuable option for patients unable to use NSAIDs. In more severe cases of gout, combining biologic agents, IL-1 inhibitors or IL-6 monoclonal antibodies, with urate-lowering drugs, allopurinol or febuxostat, can provide both short-term relief and long-term management of gout symptoms. However, the potential risks and benefits of this combination therapy should be carefully assessed. In order to effectively manage gout, it is important for patients to consistently take their medication for lowering uric acid levels. However, many patients struggle with adherence. Strategies such as patient education, regular follow-up visits, and involvement of healthcare team members can help improve adherence. Reminder systems and patient resources can also be beneficial. In conclusion, gout management requires careful selection of medications. Allopurinol and febuxostat are commonly used, with febuxostat as an alternative. Personalized medicine and novel therapies offer hope for improved treatment options. Combination therapy and patient education are key for optimal outcomes. Stay updated and provide comprehensive care.